webinar, Understanding Home and Community-Based Services with presenter Becky Prevey, Executive Director with the Association on Aging in New York. We're thrilled to have Becky with us today. This is the first of our two-part aging webinar series offered by the North Country Care Coordination Workforce Collaborative, or the NCWC, and is geared towards care managers and care coordinators. My name is Victoria Knierim, and I'm the Director of the Health Resources and Services Administration Rural Public Health Workforce Training Network grant out of the Adirondack Health Institute, through which the NCWC was established. And then for those of you not as familiar with the NCWC, it's a regional consortium of employers, providers, educational institutions, and other workforce stakeholders established to create and promote care coordination training programs, job development, and placement in rural communities. And I'm also joined by Kelly Owens, Executive Director of the Hudson Mohawk Area Health Education Center. Kelly and HMAHEC assist with North Country Care Coordination Program planning, development, and technical support. So we hope today's webinar runs smoothly. And then just a few housekeeping items. This webinar is being recorded and will be posted on the Health Workforce Collaborative website under the Care Coordination section. And Kelly will put the URL in the chat to access this and other trainings. And then we ask that you remain on mute throughout the duration of the training. Cameras are optional. And then there will be time towards the end for question and answers. So please put your questions in the chat. And again, we'd be happy to answer some of those questions towards the end. And then lastly, we have a brief program evaluation that we will email to all participants, and we'll put a link in the chat at the end of the program. Please take a couple minutes to complete the evaluation. Your input and feedback really does matter, especially if there's a topic today you'd like to learn more about. And then this webinar has been approved for 1 continuing education credit hour for social work, licensed mental health counselors, physical therapy, occupational therapy, and speech language pathology. Certificates of completion are also available. So if you would like CECs or a certificate of completion, please make sure you remain on the training for the full hour. We will be taking attendance as the regulatory bodies that provide the CE credit require your full attendance, and participants will receive certificates by email after the evaluation has been submitted and reviewed. So with that, now I'd like to turn it over to Becky, and we hope you enjoy today's webinar.
Thank you so much, Victoria, and thank you, Kelly, for reaching out and looking at the attendees. I apologize for those of you that this might be a little bit redundant or kind of a little basement level, but we really wanted to kind of do a level set as far as aging services were concerned, what's available through different insurers, what's available in the community, et cetera. So that being said, I am Becky Prevey. I'm the Executive Director of the Association on Aging for the state of New York. So I have the wonderful job of representing the 59 offices for the aging throughout the state. But what is near and dear to my heart is the work that all of you guys do. So prior to this role at the state level, really trying to advocate for the importance of the work of care coordination, case management, connection of services. I actually ran an upstate office for the aging. So I have a lot of firsthand experience on some of the work that's being done. But I think more pertinent is prior to that, I was a hospital discharge planning social worker. So really have kind of a broad lens of the service infrastructure across the state. And today's presentation is really how can we connect those dots? Because all of you are working in a space to try and assist people that have some needs in their communities. Next slide, Victoria. So I kind of wanted to start out, a lot of people that work in community-based organizations don't really understand the population of the state of New York. So I kind of wanted to start there from the perspective of where we are today and where we're going to go in the future. So we're currently 4th in the nation for the 60+ population. Not surprising, we're a large state. Obviously, we have New York City as part of that. But I think what's really interesting is when you take it down a bit and you look at the 50+ population, it actually comprises 36% of the overall total population. Another statistic that I use quite a bit in the work that we do is if you look at the entire state, we have about 20 million people that live here. But then you look at the 4.6 million over the age of 60, which will increase to over 5 million by 2030. But we also have 4.1 million caregivers. A lot of the work that all of you do in communities or through facilities or at hospitals, where you're touching those 4.1 million caregivers. The majority of those caregivers are actually sandwich generation caregivers. So they may be caring for an older loved one or someone with a disability, plus trying to raise children. And most of them are currently employed with a lot of strains on what they do, how they can do it. And that's really where the infrastructure comes into play for us to try and assist people in homes and communities. And the other segment that I like to highlight is we are losing population density everywhere except the 60 plus population. So we're losing individuals under the age of 60, but then the fastest growing overall segment of the population in the state are those individuals over the age of 80. And what's interesting about that piece is we know about 70% of people over the age of 80 are going to need some type of home care services or case coordination or care management. Next slide, please. I wanted to also talk, really every time I talk to anyone, anywhere, we like to talk about really the value of the older population. There's this misnomer that as soon as someone is older, they're a dredge on society or they have really high needs. And what we find and why we really advocate to try and increase access to services to the older population are that older people are paying about $72 billion per year in state and local taxes. When you put that in perspective of the overall state budget, it's about 43% of the tax base is being paid by older individuals themselves. The reason that that's important is we always talk about the care economy and what we're providing for older people. It really becomes an equity issue to make sure that those individuals that are paying the majority of taxes in the state are able to access services and supports in a cohesive manner. And some other statistics I always like to share. You look at their Social Security, but also volunteerism. Anybody that works in the care economy, you know, there's a lot of organizations that use volunteers. If we had to pay older volunteers for the work that they do at the fair market value, it would be worth about $14 billion per year. If we had to pay uncompensated caregivers for what they're providing to a loved one at the fair market value, it would be $39 billion per year. Again, they support a ton of jobs. Largest givers to philanthropy. And the majority of older people or people with disabilities actually live really fulfilling lives out in the community and continue to contribute. But this is more focused on that segment of the population that may have those higher needs. Next slide. So really wanted to talk about the relevance to the collective work that everyone is kind of doing, because regardless of payer source, if you're working with families or you're working with patients, you guys all understand this. There are fragments to that service infrastructure based on certain criteria, et cetera. Really what we're trying to do is show the fact that almost 40% of the overall population, whether they're older or younger, is impacted by caregiving, right? So that's one theme across all populations that we see. We never see an older individual or an individual receiving services that's just this solitary individual. They're all part of family units. Families come with their own family dynamics. You are all interacting within that ecosystem. Also wanted to make sure that everyone's really educated about the programs and services that are available that might be able to assist you in whatever service you're trying to support a family with and how those can be connected. And then really the overall focus of the work that we do in aging, the work that my colleagues do in the disability community, is really how can we have a holistic picture and a holistic care plan on anyone that we're working with. And sometimes that means there might be 1, 2, 4, or 5 different case management staff, care coordination staff, hospital staff, family supports, et cetera, that really need to all kind of understand each other's service infrastructure, but also how to work with one another. Next slide, please. So now the fun part. So aging 101. Obviously there is Medicare. A lot of people struggle with what's the difference between Medicare and Medicaid. Medicare is obviously for those over the age of 65 or someone that's had a documented disability for 2 or more years. We have different parts of Medicare. Medicare can get very, very tricky. We're currently doing an open enrollment for Medicare beneficiaries right now. This is part of the reason that I wanted to talk with all of you. Every Office for the Aging in the state of New York has independent licensed health insurance counselors that can only give objective information on a plan to go to support someone. The reason I say objective is that there are a lot of very aggressive Medicare plans with commission sales representatives that will go try to get people to sign up for a specific plan. If you go through your local office for the aging, you're getting independent, accurate information. You're going to get the best plan for you or your loved one without that pressure from an actual sales representative. Medicare comes in traditional Part A, which is your hospital coverage, Part B, which is your non-inpatient types of services like primary care, et cetera. And then Part D, obviously, for the prescription plan. And then where it also gets tricky is you have the ability to apply for Medicare Advantage plans that capture and coordinate your Medicare service infrastructure. So I always tell people, if you're not super well versed in Medicare, make sure that you work with your local office for the aging for those services. Those services are completely free for an individual that needs those types of counseling services and are really, really beneficial. And then we have Medicaid. A lot of you on this call are either working with Medicaid populations or are pretty well versed on Medicaid, because we know in the state of New York, the only payer really for long-term chronic care or skilled nursing facility coverage is the Medicaid program, unless an individual can afford to privately pay. And individuals that can privately pay either for home care at $40 an hour or, a nursing home to the tune of almost $150,000 a year are pretty limited. Almost all nursing home beds are paid under the Medicaid benefit. As you guys know, and we'll get into this a little bit deeper, you can apply for Medicaid in a variety of different ways. And there are differing levels of the Medicaid program depending on what you actually need. So if you need Medicaid home care, that's one authorization application for Medicaid. If you need skilled nursing facility, that's an entirely different supplemental application that really looks holistically at your financial picture for the past 5 years. And so through the Aging Network, I will tell you, every office for the aging throughout the state will help anybody that comes to them with applying for Medicare, Medicare Advantage. We will work with Medicaid. We'll work on getting spend downs. We will also work to connect people that are over income for traditional home care Medicaid to do what's called a supplemental pooled needs trust, which is a way to really, if you have an individual, and the benchmark loosely in the state of New York is $1,700 per month per individual. If you have someone making $2,500 per month, but they really need a lot of home care services, a pooled trust is a way to protect some of that monthly income for that member to actually become eligible and qualified for Medicaid. It's a really great workaround for people that have high needs. Through the offices for the aging, we also provide home care. This is a amazing program for people that are over income from Medicaid, but they can't afford to privately pay for the service. We go by the federal poverty guidelines as far as doing those calculations, but we do deductions for the cost of living. So unlike a lot of other programs, if you come to our home care program, you're over income from Medicaid, but you're paying a mortgage and you're paying your car insurance, we actually deduct that from your income to come up with your cost share. Our home care program participants either have 0% cost share, so they don't contribute anything because they're still considered low income, or they may pay a portion of their home care costs. We use the exact same licensed home care provider network that the Medicaid system does. So I'll give you an example. In the North Country Home Services serves the Medicaid population, would also serve our clients through our home care program. And it's just a good thing to know that there is available, because and again, you guys know this, when you're working in a family situation, you may be working, with a younger adult with some mental health issues that's living with an aging parent. What a great way for you to be able to say, maybe you should look at your local office for the aging for some of these supports, because, if you're helping any part of the family, you're helping the family overall. Again, we also provide full application assistance and benefits counseling services. So a lot of times people might call their local office for the aging and say, I'm interested in getting a home delivered meal. Cooking is pretty hard for me. Our case managers are all state certified. It's something that was mandated by law. They are all certified through Boston University of Social Work in case management services. When that case manager goes out to do their home visit, they're going to assess that client for any and all services, whether that be SNAP, HEAP, the Medicare Savings Program to get your Part B premium back. We also do a full in-home assessment that really looks at that entire family unit in totality to make sure that we're serving them at the highest possible level. Next slide, please. So this is more for you guys to have as reference, because I know I talk very, very quickly. But like I said, Medicare is a federal program for those over the age of 65, younger individuals with disabilities, or there's a couple special provisions where you can get Medicare immediately. One is end-stage renal disease. And really under that Medicare benefit, we try to max that out as much as possible. What's become very difficult, and those of you that work in hospital settings understand this, 10 or 15 years ago, before observation status was instituted, if an older person came in, more of a social admission, with, caregiver breakdown, maybe some medical issues, you could usually get that person admitted to the hospital for you to come up with a discharge plan. The problem that has now come from this with observation status is people can actually remain in the hospital, but they're under their Medicare Part B, not their Part A. And that means that they can't access Medicare to pay for any type of skilled nursing facility stay for a rehab stay. Again, it makes sense from a fiscal standpoint that people that don't have really high acuity needs need to be in homes and communities, but it definitely has become a barrier for hospitals that have people that come to their emergency departments that can't be discharged, but really don't have a medical need under their insurance to actually stay in the hospital. So that's a lot of the work that we try to assist with on how we can come up with a plan. And again, we talked about the different parts of Medicare and what can be offered. But again, I always tell people, talk to your local office for the aging. Their health insurance counselors are a wealth of information. A lot of them actually do community outreach and may work with you or your organization if you wanted further training on the specifics of different Medicare plans. Just a good resource for you to have. Next. Again, wanted to talk about Medicare covered services. This is probably redundant for a lot of you based on your positions, but really Medicare only covers home care under certain circumstances and very strict eligibility criteria and limitations. Some of the key takeaways: it has to be skilled home health care, PT, OT, speech language. Some Medicare plans will cover if you need a registered nurse to come in for wound care, have to be provided by a Medicare certified home care agency. And really it's on an intermittent basis. So these services are not long-term for people that have chronic health conditions that need management. Next slide. Again, we cover under that Medicare benefit, they will cover short-term home health aid services, but nothing custodial or long-term. Some Medicare Advantage plans may offer additional benefits. We're seeing the plans change quite a bit. Where Medicare is actually looking at covering additional services. So this is more of a moving target. There are some long-term care insurance plans that, hadn't been very fruitful for people that had purchased them in the last 10 years or so. There are some changes that are happening through the insurance industry where we might see this change. And then obviously Medicare obviously pays for hospice services. So a lot of people think that there may be a cost component to referring an individual to hospice or the need for a physician's order. Both of those are not true. Hospice will not charge you for your care. And you can get a hospice, at least informational, just from a family or friend referral. You don't have to have a physician's order until you actually enroll into that service. Next slide. I always put this important note here that because of the intricacies of the coverage and eligibility on Medicare home care, it's always best to consult either with the Medicare plan or with a qualified healthcare professional regarding the specific information on coverage and benefits. When we talk about a qualified healthcare professional, if you're working with someone on an inpatient stay, that would be the hospital staff, discharge planner, or social worker who knows these benefits inside and out. If you're in your home or community, it's a great conversation to have either with the primary care physician's office, their nursing staff, etc. Like I said, Medicare can be extremely confusing. There are resources to help. And I always like to include that each area agency on aging or office for the aging has certified counseling services where you can reach out to get that assistance, and the number is included here. Next slide. So Medicaid is a joint federal and state program. It provides health coverage to low-income individuals and their families. Every state in the country is different when it comes to Medicaid coverage and Medicaid eligibility. A lot of people think that that's standardized. It's absolutely not. Medicaid in the state of New York is actually more robust than a lot of other states. You know, when you look at states like Georgia and Tennessee, the work that we do under Medicaid and the available services that are available under Medicaid look much different than they look in the state of New York. Of note, Medicaid is a huge program. So the overall state budget in the state of New York ranges between $230 and $236 billion per year. Of that, the state Medicaid program is over $100 billion of that budget. So it's a very, very costly service, but it provides really great benefits for the members that are able to receive Medicaid. Again, it pays for doctor's visits, hospital stays, prescription drugs, lab tests, preventive care. We're in the middle of our next 1115 waiver. A lot of you on this call probably lived through the DSRIP initiative, which was really to change the Medicaid system, reduce hospital utilization. This is not DSRIP Part 2. This is a new waiver, but it's really laser focused on social care and how community-based organizations are really, you know, taking that heavy lift as far as the healthcare system is concerned. Medicaid is the payer for long-term in-home services like chronic care, home health aides, and nursing home level coverage for an individual that does need to go to a facility. I will also say if you're working with a client that's looking at nursing home placement and that Medicaid application, those can become very difficult. The burden of proof from the consumer perspective on the 5 years of financials and, you know, associated documentation can get very burdensome. I will tell you one of the things that New York State Office for the Aging did that I think is wonderful is they have developed and recorded videos that are now on YouTube. You can go to the New York State Office for the Aging YouTube page. And if you have new staff that you want to train on applications, these are literally videos of an individual sitting down and going line by line through an application. So either individuals in their own homes can complete applications for benefits, or if you have staff that need training, they can use those videos as a resource, which are really, really beneficial for training if there's turnover, et cetera. And those are all free of charge. Next slide. So again, we talked about this long-term care services for those that have needs with activities of daily living, and then HCPS waiver services to help people remain in homes and communities. We look at these like, you know, all the wonderful work that's being done through the Health Home program, a lot of the waivers with behavioral health to support people that do need assistance or supervision in the community. With, you know, a lot of adult day services are covered through waiver programs. And then obviously the one program that can actually, depending on where you are in the state of New York, can provide 24/7 care through a waiver program is the Nursing Home Transition and Diversion Program and the Traumatic Brain Injury Program, which unfortunately have very long wait times, but they are able to bring people back into homes and communities that need that 24/7 care that's hard to access under different service infrastructures. Coverage under Medicaid, I also will state, and this is something that's changing at the state level currently, but you are able to access the Consumer-Directed Personal Care Assistance Program under the Medicaid benefit, which means you can actually hire one of your own loved ones, family, friend, neighbor, to provide your personal care, and they can get reimbursed through the Medicaid benefit. Prior to some legislation that just passed, there were about 600 fiscal intermediaries throughout the state that ran this program. The state has now awarded one fiscal intermediary for the entire state called PPL, and we're waiting to see who PPL will contract with, but I will tell you, part of that law actually mandates that PPL holds contracts with the independent living centers throughout the state, which predominantly hold those FI contracts. Offices for the Aging can also provide consumer-directed care through their local office for the aging. Not every county in the state is actually utilizing the consumer-directed program, but 42 out of the 59 offices for the aging do provide the consumer-directed program. Next slide, please. So again, a lot of you guys are going to be well versed in Medicaid eligibility. It's really easy to find through New York State Department of Health, but it's really it's a variety of different factors, right? So it's the income, it's the household side, it's your disability status. It's been expanded under the Affordable Care Act. A lot of you may have used the exchange to get benefits for individuals. And they do provide some coverage or some plans for individuals that have incomes that are above that Medicaid benchmark. The managed care program is New York's overarching Medicaid program went to managed care years ago, where the beneficiaries receive care through these MLTC plans. Some of them are starting to offer additional benefits, which is very, very interesting, specifically on the older population. Some individuals that are dually eligible for Medicare and Medicaid, which is absolutely a thing. So just because you've hit 65 and you've been on Medicaid does not mean you lose your Medicaid benefits. You get those in addition to your Medicare benefits if you're still income eligible, and gives you kind of that extra insurance, which is very beneficial if you need any type of higher level of care if you have both. So we're working with a lot of the MLTC plans for, what else can they provide as part of that package of services that kind of helps overall population health, whether that be, gym memberships or other ancillary services that we know might increase the overall health of the population. Next slide. So again, just wanted to let everybody know there are different ways to apply. The marketplace is probably the easiest way, if you have access to the internet and you're in someone's home, for you to be able to apply. You can also contact your local Department of Social Services to get an application, complete the application, and submit the application. But you need to be really, really thorough in your documentation, because Medicaid does require a great deal of information to be submitted to them. But again, if we didn't have Medicaid at the level we had in the state, we wouldn't see a lot of these waiver programs. And we would see a lot of low-income individuals that would be forced into institutional care without Medicaid providing the level of home and community-based services that it does. As an advocate and my work in lobbying with state government, I will always say we can do better for the vulnerable population. But Medicaid really is that conduit where we're able to serve a lot of people who have needs, who want to remain in homes and communities. Next slide. So this is the fun part for me, right? Everybody thinks, well, if we can't serve the older population in the community, they can just go to the nursing home. We started off this conversation by talking about demographics, and I'm not great at math, but I will tell you this math doesn't make sense, right? You have 4.8 million people over the age of 60. That's going to reach 5 million by 2030. We currently in the state of New York, in the last 2 years, we've gone from 160,000 licensed skilled nursing facility beds to 111,101. Those are licensed beds in the state of New York, and this number fluctuates slightly, but on any given day, there's only between 96,000 and 100,000 people that are actually filling those beds. I'm sure all of you see this in your regions. We are losing skilled nursing facilities. We're losing assisted livings. The one assisted living that was actually available in St. Lawrence County, which is the largest geographic county in the state that's the size of Connecticut, there are no assisted living beds left in that county. What does that mean for individuals and families? It means essentially that you are now taking someone well over an hour away from the place that they have lived, which makes family visiting very, very difficult, etc. But so again, I wanted to put that in front of this group to really know that those resources are really, really drying up, and they're going to be harder to get to. Many of you know this that have worked with any type of bariatric patient with mental illness issues, patient without payer, patient with dementia or any wandering behaviors. Really hard to get some nursing homes to take those patients because of the staffing crisis that we see across the state of New York. And again, Medicare only pays for a very short period of time. And the reimbursement rates on the Medicaid side, if you talk to any provider, they'll say that they lose money per patient per day on Medicaid clients, even in institutional settings, because those revenue streams are so low. Some Medicare will pay if you qualify. So perfect scenario to get Medicare to pay for any type of skilled nursing facility stay. Older person has a fall, might lay on the floor overnight, develops a urinary tract infection, which needs, IV antibiotics, goes to the hospital, is sick enough to be admitted to the hospital, stays in that hospital for 3 overnights, works with physical therapy, starts making gains, then Medicare will pay for that individual to go to a rehab facility for those rehab services. Medicare will not pay if you bring your mom to the emergency department and say she's been wandering, I can't care for her, I have to work tomorrow. Medicare is going to pay for nothing. So always like to educate people that are working public facing with any type of family that this misnomer that your Medicare will pay for things like going to the nursing home are very situational dependent, and it's not something that you can rely upon happening on behalf of these individuals. Next slide. Again, home care services, you guys are probably well versed on this. There's certified home health agencies that provide part-time intermittent health care and support individuals who need those short-term skilled services. A lot of the CHAs can also provide long-term nursing and home health aid services for oversight and supervision. And that's really where you're going to get your home physical therapy, occupational therapy, speech therapy, wound care. And these services are covered through the certified home care agency under Medicare as appropriate. So again, I talked a lot about eligibility for these programs. It's very nuanced. But if you can check all those boxes and Medicare says, yes, you need these services, they will pay for that physical therapist to come to your home and provide those services in home until you reach a plateau. So the minute your provider says, Becky, we think we got you back to your baseline, we're not seeing any further improvement, then Medicare is no longer going to cover those services. Next slide. The licensed home care provider services agencies, again, the licensure is different than the certified. They do have to have their license approved by the state of New York. So there's a ton of oversight and supervision for licensed home care providers. They employ and coordinate those caregivers, including home health aides, other healthcare professionals, and they provide a range of home care services to clients. They do provide non-medical and medical services. So you can get personal care level 1, where someone's just getting some assistance like making a meal or maybe picking up groceries, all the way to, helping with medications, helping an individual take a bath, etc. They are regulated by the state health department. Again, unfortunately, statewide, due to budgetary issues for licensed home care providers, we are losing licensed home care providers every day. And any of you that have tried to access home care workers, especially in the North Country, it's very, very difficult in some of the regions of the North Country to even get a home care worker to be able to fill a case, even if the case is authorized for service. So unfortunately, we've just had 4 licensed home care providers in Western New York close because the revenue stream from Medicaid is not enough to support their operations. And I think all of you know this, not only those that are working in care coordination that are doing home visits. If you're a home care worker, you have to have a reliable vehicle. You have to have snow tires on that vehicle. You might have very unknown work schedules if one of your clients goes in the hospitals or to a nursing home. And then the pay obviously is equivalent to what you could make in retail or fast food establishments. So it's really hard to recruit and retrain quality home care workers, which is why in times the consumer directed personal care assistance program is the only way you'll be able to get your client or their family home care assistance with those activities of daily living. Next slide. So really quickly, I wanted to highlight this slide for a variety of reasons, but number one is a lot of people that I talk to that are outside of the Office for the Aging realm have this assumption that offices for the aging really only provide home delivered meals or run some senior center sites. And I wanted to make sure that you guys, as a resource across the regions that you're working with, is that offices for the aging provide a whole host of other assistance that are listed here. I'm not going to go through them all in detail. But I think pertinent to the work that you do, every Office for the Aging in this state runs the highest level evidence-based interventions, including chronic disease self-management, falls prevention, etc. We provide legal services for individuals that can't afford to privately pay for an attorney for advanced care planning, estate planning, those types of things. We also have the health insurance information counseling program I talked about. We also offer comprehensive case management. So our case managers, like I said, are state certified under law. They do ongoing home visits. They know these families inside and out. So even if you're working with a client that's not older, but they're living in a multi-generational household, if you know an individual is receiving services through your Office for the Aging, make the connection with their case manager. I always say when you're coming up with a care plan or working with a family, the more people that are having a look at that to see what the best outcome could be, the better. And our Office for the Aging staffs will absolutely work with you on what services we're providing and how we could work together, obviously with consent. We also pay for ancillary services like personal emergency response systems. We provide transportation to medical appointments for non-Medicaid eligible individuals. Again, huge issue in the North Country. Medicaid, although it's a somewhat broken system, will provide transportation to medical appointments for Medicaid beneficiaries. On the flip side of that, there is no payer source under Medicare that will pay for an older person to make it to an appointment, and we subsidize that through our transportation program. An example is in Essex County, they actually have the county runs its own van that will bring people to medical appointments. And again, a lot of the work that you guys do, you might be sending people to Albany or Burlington for specialized care. So transportation is a huge issue. And then we do a ton of work. And if there's interest based on feedback, I will include this in our next presentation. We are doing a ton of work to combat social isolation and loneliness with online platforms, including robots that we're putting in people's homes, the animatronic pets. So really a variety that I can share next time if it would be valuable. Next slide. I apologize, I'm getting over a cold. I didn't want to have a coughing fit. So I wanted to also share with you guys, just so you had a pretty good view of all the information that we're obtaining. This is our assessment information. So I think the reason I wanted to share this is we're not just going in and saying, Mrs. Smith, do you need a meal? We are literally evaluating her house for trip hazards. If there's pets in the home, do you have an ability to self-evacuate? Do you have any ongoing issues that you might need to be thought about? We look at your home energy checklist. We look, who are your social supports? Who are you interacting with? We provide assistive devices if people can't get those through their insurance company. We do a full psychosocial assessment. So we know if individuals have alcohol and substance abuse issues, if they're having mental health issues. We do a tech check to see, is someone able to use the internet? Are they comfortable using the internet? If they are, can we connect them to our online platform for many interactions that they have? We look at their veteran status. Can we connect them with VA services? And then again, screen for any and all benefits and entitlements. So again, say I'm working in care coordination or case management with a 25-year-old, but I know grandpa lives with him. I know if I connect with my local Office for the Aging, I'm going to get, not only all of the background on that household, but I'm also going to know about that interaction between the older person and that child or grandchild, which is always really, really beneficial when you're trying to do person-centered holistic care and care planning. I think it's also really beneficial if you have any reporting requirement, either back to a primary care physician's office or to a supervising agency, or if you're working within the healthcare system, if you have the complete picture to report back on, it gives the clinician a much better idea if they're treating someone either for a mental health issue or alcohol and substance abuse issue, really have that clean outside assessment of how things are really going in the home, because that can really shape a treatment plan and where that goes. Next slide. Wanted to talk really briefly about the New York Connects program. That is a state-run program. It's considered our ADRC, or Aging and Disability Resource Center. The wonderful thing about the New York Connects program is it's run through your local Office for the Aging, but you can call the New York Connects program and you can have a question birth to death. So you could be a mom looking for early intervention services. You could contact New York Connects through the local Office for the Aging. Obviously, Office for the Aging staff are not going to make that referral and enroll you in early intervention services, but you will get connected to the appropriate place. The reason this is so amazing, and I'm sure all of you have seen this in the work that you do, when you're working with families, and many times they're at a crisis point. They're at a point where at times they don't even have the ability to go online and do a Google search of who is my early intervention coordinator in my area. New York Connects is there for those types of questions. It's also there for professionals. So if you want to call New York Connects, and run a scenario by the New York Connects intake worker, you can do that. And you can do it, by saying, well, I don't know if so-and-so is eligible for a home delivered meal. They're going to tell you, can we get that person enrolled in the home delivered meal program? So it's really there as an asset for all of you, to make sure that you're utilizing any and all services as necessary. And I will tell you from previous experience, in doing home visits or doing care coordination plan at the hospital, there were times with those really high intensity patients, they might have an adult protective services caseworker, they might have an office for the aging worker, they might have a community worker, they might have a mental health worker, they might have the social worker at the hospital, they may have a medical home care manager. I never looked at those as territorial issues. I looked at those as, what can each entity pick up to assist this individual to be in the least restrictive setting, with the best outcomes overall. And I find that very beneficial. And I think if you take that kind of lens in the work that you do to try and forge those connections across those service ecosystems, it makes your job a lot easier, but it's also the right thing on behalf of everyone that we're trying to serve. And New York Connects is a great way to really make sure that you're engaging and that you're aware of anything that would be available in the community for someone. Next slide. New York Connects has a couple key components. One is information and referral. So your New York Connect staff are going to know everything there is to know about long-term care services and supports, how to get connected with those home and community-based services. They, many times the Office for the Aging knows the social work staff at the skilled nursing facility on a very first name basis, because they talk all the time, do cross referrals. Options counseling is really another tool within New York Connects where, and a lot of you see this, you have very, very complex patients or clients. In our world, a lot of options counseling might revolve around a family that's really struggling. Do I keep my loved one home, or do I look at a nursing home placement for that individual? That's when our trained options counseling staff can come in and really not direct the process in any way, shape, or form, but put the information in front of the family in a digestible way, for them to come to an informed decision on what they're going to do. The nursing home one always is very difficult, because you have families, and I tell people this in my personal life, never tell your child, don't ever put me in a nursing home, because if you ever have a medical event that makes you total care and your kids have to make that decision, the guilt that is carried from people having those conversations and saying never do it, will haunt those kids the rest of their life. So that's just a sidebar. But on like a nursing home placement conversation, you could have an individual that a family decides to keep their mom home. 48 hours after they make that decision, mom falls, hits her head, has a subdural hematoma, and passes away. Family's going to feel guilt forever. Same thing can happen. Mom could go to the nursing home in 48 hours, fall in the bathroom, have a subdural hematoma, pass away. Family would have that guilt forever. So options counseling is a way for us to put all of that information in front of a family so that they then can make those decisions. And then again, assistance with applications. I will also share with all of you, we're working at the state level through the master plan for aging process to attempt to create and implement a one size fits all application. So if you do this application, you automatically, if you're eligible for HEAP, SNAP, Medicaid, daycare subsidies, you name it, based on that application, you automatically get all those services. And that would alleviate such massive staff time and barriers for individuals that have to do these individual applications and then submit them with recertification periods that don't often align. So that is something we're looking at. We're years away from doing it, but the conversation is being had at the highest levels of government, which we're excited about. Next slide. We also provide care coordination. So we help with care transitions of individuals moving between different care settings. I will tell you, if you look at any state or national data, the biggest area of risk for an older individual or an individual with a disability is transitions between clinical settings and the community, whether that be discharge from a nursing home or discharge from a hospital. That is your number one trauma point where you run the highest risk of something going awry. Which is why I argue all day long, being a discharge planner as a social worker is one of the hardest jobs that there is, because then the blame game always comes back, even though we know that's the highest rate of something happening to an individual. So really try to help with those care transitions, making sure home care services are arranged and provided. Also, a lot of support is given to caregivers and family members who are trying to manage that care of a loved one. And again, I hope to share this if I'm invited back for a second presentation. The tools that we have for caregivers, many of them completely free, are really, really amazing. And it's something that I wish every person that's touching a family or doing a home visit has as a tool, because again, these people live within families that have their own needs as well. We also provide access to resources, support groups, transportation assistance, meal programs. And really the goal of the program is to empower individuals, right? And it's something that we continue to advocate for additional funding for. And, I would be remiss if I didn't say the capacity in all the work that you do and the capacity at all the offices for the aging is strained. So this is what the program does. Can we return phone calls within 24 hours? And many times, probably not. You guys are seeing this in the work that you do as well. It's just very, very difficult with staffing issues, and trying to stretch every resource as far as you possibly can. Next slide. So again, this is kind of the overall tone of what I wanted to talk about today is what is the importance of cross collaboration? Like, what is the importance of us not just remaining in our own silos with our own tight job description of who we can help? Well, because we're working with a whole host of individuals that touch an individual or a family. Cross collaboration improves efficiencies. If you have good working relationships with other service providers, you guys know this, you can pick up the phone, make a call, get help. Everybody has their own knowledge base and what they're really, really good at. And so if you're not as well versed in benefits applications and assistance, leverage your resources that are. Everyone brings their own real strength to the work that they do. And again, working with all these providers to provide holistic care, which really drives better patient satisfaction. A lot of the work that's being done either through Medicaid, through Medicare, through primary care, or hospitals is graded based on client satisfaction. And you are going to have higher client satisfaction if you're working as part of a care team instead of individualized. And you guys know this, I would go into homes where someone would say, well, Kathy helps me. And I would say, well, who's Kathy with? And the client might not have any idea where this individual is from, typically through an agency, maybe a home care worker. But those are important things to know so that you're not duplicating services and you're really part of that overall holistic thought process with that individual. Again, it addresses complex client family needs. You guys know this, resources are incredibly limited. And that's across the board. Resources are limited, whether you are in an acute care setting, if you're in a community-based organization setting. Staffing probably is number one, but also financial resources and access issues are all really, really prevalent across this region. And there is vast confusion, like I talked about. And I would argue all day long, the aging population touches every population because we're aging in families. And I think one of the things I heard recently that has resonated with me is everyone thinks of the family unit as the Hallmark Christmas card, right? Where there are no issues, everyone gets along. The fact is nothing could be further from the truth. The family is probably the most dysfunctional unit that exists. And so as you are doing your work within families, those families go across many, many generations. And how can we work together to kind of connect those dots to make sure that the services are being provided in the best way possible. So I would welcome any questions or further information that any of you have on any of these topics.
Thank you, Becky. A lot of great information shared today, and you always do a nice job presenting. And we look forward to your next session in this series. I believe it's planned for January 9th, same time, and we'll be sharing more details and the registration link for that soon. So Kelly, how does the chat look? Do we have any questions coming in?
Right now, no, the chat is empty.
So we can hang on here for a few more minutes just to see if anyone has questions.
Or there's an opportunity if folks want to take yourself off mute We do have a question that just popped up. Is transportation for food, shopping, or other stores too?
It depends on the region, but transportation can be used for any and all of those. So if someone needs to go to a medical appointment, if they need to go to the grocery store, again, it depends on capacity. So like I'll speak to like here in Franklin, if you need transportation to the grocery store, they might connect you with the Community Friendship Volunteer Program. But if you needed to go to a medical appointment, then that might be provided through the actual Office for the Aging. But they will know who can provide those types of assistance for food, grocery shopping, those types of things.
And Erica said, thank you.
You have the most quiet group I think I've ever presented to if they don't have questions.
Yeah, with the group that we have, feel free to take yourself off mute, excuse me, to ask Becky any questions you might have, or continue to pop those questions in the chat.
Becky, this is Victoria. I have a question for you about hospice. I currently have a friend going through chemo, and I was told that he's not eligible for hospice, and I was really surprised by that.
So the hospice criteria are that a physician is comfortable certifying, because they do have to sign a physician order, would be comfortable certifying that they would not be surprised if an individual passed away within the next 6 months. The one excluding criteria for your friend is if you do enroll in hospice, then you can no longer seek any treatment unless it is palliative in nature, and that gets kind of sticky. But any curative treatment is no longer allowed once you go on hospice. So you're not allowed to go to radiation, and you're not allowed to still receive chemotherapy. You're also encouraged to not go to the hospital if you are enrolled in hospice, and you manage those at home. So there are instances where someone might be on hospice, and then they decide, say it's an end stage lung disease client, and they get short of breath and decide, I want to go to the hospital. They may be disenrolled from hospice because they're going in for treatment and care that's above managing chronic pain and the end of life processes. There are some instances, and this is why I always encourage people. People get scared. They think a doctor has to refer someone to hospice. I could call hospice tomorrow and say, I want to consult on so-and-so. And they would come do the consult and then contact the physician's office. There are some instances for certain types of cancer diagnoses where if an actual malignancy is in the joint of a bone and it's causing excruciating pain, that individual might be able to get some palliative radiation. But in order to enroll, even if your I use this example, even if you have pancreatic cancer and your physician has said, I don't think you're going to survive this event. If that individual is still seeking chemotherapy, they can't go on hospice service. And the reason behind that, not that everything comes down to fiscal, but to give an explanation, once you're enrolled in hospice gets paid under your Medicare benefit a set rate, and then the entirety of your care comes out of that set rate. So the reason hospices have, fundraising arms is, say you have a patient that comes on hospice and you get this flat Medicare reimbursement rate, but then their medications, because of their disease process, cost 4 times what Medicare pays the hospice. That's why there's the fundraising component. So if hospice had to pay for chemotherapy drugs out of that, one time per day payment, they would go bankrupt, essentially.
Oh, thank you for explaining that. It's very helpful.
I will also say we are ranked worst in the nation for hospice utilization, which I think is a travesty. I think hospice is a wonderful program, but people just aren't referred. If I work a lot with the Hospice and Palliative Care Association, most people coming on hospice, you get the most benefit because of the social work component within hospice. If you're on hospice for, a couple months, people are going to hospice and they're either dying before they get home in the ambulance, or they're living, 24, 48 hours post-discharge with hospice, which you don't really get the benefits. So that's definitely something to be cognizant of. And again, I always say when I present to people, don't just use this for your professional experience. Like, everybody is part of a family. Everybody has aging relatives. Like, it's really good to be educated about these things.
Great. Well, thank you. You're a wealth of knowledge, and just the information that you shared today. It's just incredibly helpful. And we'd love to stay on and continue, chatting with you, Becky. Kelly, I'm not sure if there's any other questions coming in, but
no questions, just a comment
Okay.
about requesting palliative care, and then learning more about what hospice offers. People are very appreciative of sharing information about hospice.
yes. And then Kelly, did you put the evaluation in?
Yes, the evaluation is in the chat box, and I will send an email at the conclusion of the training. So later, early this afternoon, I'll send that information out along with the link to Health Workforce Collaborative as well.
Awesome. Well, thank you guys so much for having me. And, like I said, for our next presentation, I would welcome anybody that has suggestions about what they'd like to learn more about. I will plan on presenting on all the wonderful technology innovations that are completely free that you can start deploying with any family you're working with, which always gets you a gold star. And I also plan to talk a little bit about adult protective services, because there's some misnomers there that I think would be beneficial. And then anything that you guys collectively have further interest in, I will absolutely be willing to talk about. So I thank all of you for the incredible work that you do. It's really difficult work, but it's so impactful for the families you guys are all working with. So I appreciate being here today.
Yes, thank you, everyone.